So a very good evening to all the participants, all the students. I think all are going to have the exams in December. So it is a very important topic today, that is anatomy, physiology and imaging of the thyroid gland. Actually, I will not be like covering very each minute detail, but all the very relevant points which will be important for you in practicals, I will be discussing that. Okay. So it will cover basically the basic anatomy, physiology, some evaluation tools of the thyroid disorders we will discuss, about hypothyroidism, hypothyroid, and some post-thyroidectomy management we will discuss. So what about the embryology? Every anatomical aspect, basically, we should know first about the embryology. So few important points are like the thyroid gland has got the dual origin. It is the endocrine organ which has got both your origin from the ectoderm and the endoderm. So endodermal component is like basically it arises from the junction of the first and second pharyngeal pouch. So what it is basically, it is the future foramen cecum, which is like the origin for even your thyroglossal duct. So when it persists, your duct may when the thyroglossal duct persists, it is like a tract running from the foramen cecum till your isthmus of the thyroid gland. Okay. Ectodermal component is like it is constituting majority of the calcitonin producing C cells, and it is derived from the ultimobranchial body, and it forms the posterolateral aspect of the thyroid parenchyma. So there are few important anatomical structures which are present in and around the thyroid gland, which we should consider especially when we are doing the surgeries. Like first important thing is the pyramidal lobe. Pyramidal lobe is present in around 44 to 61% of the cases, and it is basically like arises from the superior border of the isthmus. But mostly it is in the paramedian positions and more in the left side. Mostly it is seen that it arises from the left paramedian position, and it is basically a thickened fibrous band. What happens is, what is the importance actually of the pyramidal lobe? When you don't dissect it, as it is the remnant of the thyroglossal duct only, that is the persistence of the thyroglossal duct at the distal end. That's why it lies at the superior border of the isthmus. So when we are not removing it totally, then it may cause the recurrences in the form like the recurrence of the recurrence even after the cisterns operation. Even in toxic nodular goiters, there is sometimes the compensatory hyperplasia of this particular pyramidal lobe. So it is leading on to the recurrences when, even in cases of total thyroidectomy done for some cancers, and if we have not identified this fibrous tract and we have not removed this, then it may cause the recurrences. It is important. So another important landmark in and around the thyroid is your tubercle of Zuckerkandl. So what is the tubercle of Zuckerkandl? Basically, it is the condensed thyroid parenchyma. Okay? And it is located around the cricothyroid junction at the cricothyroid level. So it is at the posterolateral aspect of the thyroid gland, and depending on the size of the tubercle of Zuckerkandl, there is one classification was given. It is like when the size of the Zuckerkandl is less than 0.5 centimeter, then it is type 1 Zuckerkandl, tubercle of Zuckerkandl. When the size is between the 0.5 to 1 centimeter, then it is type 2, and when it is greater than 1 centimeter, it is type 3. Okay, so mostly in most of the cases, 45% of the cases, you will see Zuckerkandl type C, and it is one of the landmark for recurrent laryngeal nerve. Even though it is not a bony landmark, but it is also a good landmark in 60 to 80% of the cases to locate your recurrent laryngeal nerve. Your recurrent laryngeal nerve will this was your pyramidal lobe actually. Okay, and here it was the your tubercle of Zuckerkandl. Beneath this tubercle of Zuckerkandl, your recurrent laryngeal nerve will enter into the larynx. So these are the two important sites. And one of the important thing about tubercle of Zuckerkandl is it is also one of the site for maximum density of C cells. So here you have to preserve the vascularity, okay, so that you don't hamper the secretion of calcitonin. And it is also very important in cases of it has to be excised in cases of medullary carcinoma of the thyroid, because calcitonin C-rich cells are mostly present in the tubercle of Zuckerkandl area. So that is the surgical importance. Then there is one important structure, because we know we identify two nerves in cases of thyroidectomies. One is the external branch of the superficial nerve and another one is your recurrent laryngeal nerve. So superficial laryngeal nerve we identify at the superior pole of the thyroid. So one of the classification has been given by Sarnia and Friedman for the superior laryngeal nerve branch. That is, it is like depends on where it is located above the superior pole of the thyroid. There is one space around the superior pole of the thyroid where the superior laryngeal nerve lies. So mostly during the thyroidectomies, there is type 1 is given as when it is more than 1 centimeter above the plane which crosses from the superior pole of the thyroid to the superior thyroid vessels. There is a plane, you make an imaginary plane from the superior pole of the thyroid crossing the superior thyroid vessels. So superior, when we call it as type 1, then it will be like it is more than 1 centimeter above this plane. Okay, more than 1 centimeter. When it is up to the 1 centimeter, it is type 2A. And when it is within 1 centimeter, then it is type 2B. So type 2B will be like more has got more chances to get damaged during the thyroid surgery when you are ligating the superior pole of the thyroid. Okay. Then another important structure which is to be taken care of, or which is very important in thyroid surgeries or in the making of the thyroid gland, is the pretracheal fascia. Actually, it forms a pseudo capsule of the thyroid gland and it lies outside the true capsule. So pretracheal fascia forms the pseudo capsule of the thyroid gland and it lies above the true capsule. So you have to be very near to the true capsule to preserve the parathyroids, especially superior parathyroids and even inferior parathyroids. So when you are in the true capsular plane, you save the parathyroids. So you have to identify where is the pseudo capsule and where is the true capsule, because you have to do the capsular dissection, true capsular dissection. Okay. And it is also one of the barrier against the extrathyroidal extension of any thyroid malignancy. And one important space comes in relation to the thyroid is thyrocarotid space. Means this is the diagram which is showing this one. Here will be your thyroid. Here it is your internal jugular vein. This is the common carotid artery. In between there will be the vagus nerve, and here is your inferior thyroid artery. So when you retract the strap muscles, lateral border of the strap muscles, and between the carotid, this space is called as thyrocarotid space. So what is the importance of thyrocarotid space? The second diagram is also showing the same. Inferior thyroid artery is very prominently seen. It is the avascular space except there is the inferior thyroid artery. Okay. So this space, why we are want to know about the thyrocarotid spaces, because it is like a lateral approach which could be done in the cases of revision surgeries. When you are doing the midline approach in the initial surgeries, initial cases, you are doing mostly in the midline approach. But when the goiters are very large, very huge, then you need to do the lateral approach. Median midline approach becomes difficult. And in the revision cases also, it becomes like difficult to do from the midline approach, because the midline has been distorted by the previous surgery, would have been distorted, and you could not find the true midline. So it is better to go with the lateral approach. And it is like all the great vessels in your view, when you are doing for the large goiters, the lateral space will not be seen. So if you're entering through the lateral space, then you will be able to see the major vessels in your view. You will have the major vessels in your view, and you will be very away from the proper thyroidectomy dissection site. So there are very less chances to damage the important structures. Okay. One important structure is your ligament of Berry. Okay. This is the condensation that is called as ligament of Berry. Okay. So this actually connects your it is basically the condensation of the pretracheal fascia itself, and it connects firmly your thyroid to the trachea and to the cricoid. So whenever you are doing the medial rotation of the thyroid, then it can cause traction or kinking of the recurrent laryngeal nerve. So we have to be careful while dealing with the area when you are dissecting around the ligament of the Berry. And it is one of the source of invasion. It could be a protective thing also, and it could be a source of invasion where it is a source of invasion into the airway. So when there is a poorly differentiated thyroid malignancy, it will enter into the airway through ligament of Berry. This is just a picture taken from the Google, just to show you the sites where all there are the maximum chances of damage of the recurrent laryngeal nerve, or in other way, where all the places where you can see the recurrent laryngeal nerve when you do the dissection. So this is the thyroid lobe. This is the towards your cephalad superior pole, and this is your inferior pole. So there are few. First site is your at the posterolateral aspect of the superior pole. This is the superior pole, and just there are the superior parathyroids near to the capsule of the thyroid gland. So when you are medially rotating this thyroid and you are seeing the superior parathyroids always points towards the recurrent laryngeal nerve. This is your recurrent laryngeal nerve. Yellow structure is the here the recurrent laryngeal thread like structure is the recurrent laryngeal nerve. So parathyroids, even superior and inferior parathyroids, both points towards the recurrent laryngeal nerve. इस तरह से होता है कि जैसे आप थोड़ा सा नीचे देख के आंख दिखा रहे हो, तो फिर जैसे आप जैसे पैराथायरॉइड जब होते हैं तो दे विल सी व्हेन यू सी डाउन योर आईज एंड पैराथायरॉइड लाइक पैराथायरॉइड योर आईज, and when you point down your eyes you will see the recurrent laryngeal nerve. Okay, so here are the superior parathyroids just below the superior parathyroids, wherever they are pointing near to the this esophagus, that is a tracheoesophageal groove. In the left side your nerve will be lying into the just inside the tracheoesophageal groove, while in right side it will be little bit lateral from the tracheoesophageal groove. So first site of injury is this one below the superior parathyroids. Then second is the site where there is a crossing beneath the inferior thyroid artery. Second is this site. And third one is the site where you try to ligate the thyroidema veins, or you try to cauterize the thyroidema veins to control the bleeding over the trachea. And at that instance, you may damage the recurrent laryngeal nerve. So these are the three common sites of injury. Then the very simple slide to know the physiology. There is not very much about the physiology. Only thing is when there is alteration of T3, T4, TSH, and the like whether only one component is altering, TSH is altering, whether with the TSH T3 is altering, or with the TSH T4 is also altering. So all these three permutation combinations will lead on to the formulations of hypothyroid, hyperthyroid, subclinical hypothyroid, and subclinical hyperthyroid. So what you all know, from the hypothalamus and pituitary, we are regulating two hormones, that is TSH and TRH we are regulating. Okay? So whenever this T3, T4 are increasing, then there is feedback suppression of the TSH levels, and ultimately that will suppress the TSH level. Same thing is there when T3, T4 are decreasing, TRH will increase, TSH will increase, and that will suppress the T3, T4 again by the feedback mechanism. So if TSH is high, then the brain will take over the action, and that will lower down the T3, T4 secretions. And when the TSH is low, that will create a feedback action in the brain, and that will suppress raise the T3 and T4 levels. So there is a opposite inverse relationship between the TSH level and T3, T4 levels. So this is one of the permutation combination, which is a very important slide for all of you to note down. So when we call the things, just wait a minute. So for better understanding, we will see primary hypothyroidism. When it is called as primary hypothyroidism, when the TSH level is high. So that is a basic primary hypothyroidism. So when it will be called as low, like in that cases, what about the T3 and T4? Both will be low, but T3 could be either low or normal. So what is the primary hypothyroidism is? TSH will be definitely high, T3 will be low, and T4 will be low. Okay. When it comes to the subclinical hypothyroidism, definitely because it is hypothyroidism, TSH will be high. But in these cases, there will be normal levels of T3 and T4. As you know, in many of the cases, when the patients are coming to the OPD, we are haphazardly writing 50 microgram of thyroxine, levothyroxine, whatever we are writing, and we mostly don't correlate with TSH, T3 and T4 levels. So it is a basic slide to let you know how we should track down the things, when to level it as primary or when to level is at subclinical. So primary hypo is TSH is high, T3 and T4 will be low. Subclinical will be when TSH is high, but T3 and T4 will be normal. So what about the same thing? Primary hyperthyroidism, TSH should be low and your T3 and T4 should be high. Then subclinical hyperthyroidism will be same. TSH has to be low and T3 and T4 will be normal. So have you understood the things? See how it counts? So TSH and TSH will be low and high according to the hypo and hyper status, and you have to look for T3 and T4 to denote it as primary and to denote it as subclinical. Then again, there are certain other things like secondary or central. When we should call or when we should think of you are giving the treatment and patient is not improving, that means there is something which is related to your central level. So in case of central hypothyroidism, then there will be either low TSH or TSH could be normal also. What will happen? There will be either low TSH or TSH could be low also. Same happens with the T3. There could be low TSH and normal TSH, but in this case, T4 will be always low. So in case of central hypothyroidism, T4 will be always low. There is one entity called as factitious thyrotoxicosis. In this case, it is a false, factitious. It is not the true thing. So there will be TSH will be low or normal, T3 will be normal, and because it is a thyrotoxicosis, so T4 will be in a very high quantity. Then there is a one entity, in the name itself you can see T3 toxicosis. So there will be high levels of the T3 rather than the T4. So low T3 syndrome or sick euthyroid syndrome is one of the entity where there will be low T3 level. Then there is one entity called as thyroid hormone resistance or TSHOMA, in which there is high secretion of the, or you can say there is a tumor which is secreting more level of the TSH. So in those cases, TSH level will be high, in T3 will also be high, and T4 also will be high. They could be normal also, but mostly they will be high. So this is one of the entity which is called as thyroid hormone resistance, because all are not responding to each other. Everything is getting onto the higher levels. They are not getting suppressed. So what usually we should do in cases of any, what are the investigation tools basically? So routine test, we all know we are doing regularly for any patient who is presenting with either the signs or the symptoms of thyroid or hypothyroid disorders. We usually give them the free T3, T4, TSH levels. Then we go for USG thyroid, and if there is some nodule, then we advise the FNAC. So these are the basic tests. Sometimes we deal with a special test, like if we are finding any autoimmune disease, we are suspecting any autoimmune thyroiditis, then we are ordering for thyroid antibodies. Mostly 3 types of antibodies are being ordered, like anti-TPO, that is anti-thyroid peroxidase antibodies, anti-thyroglobulin antibodies, and TSH receptor antibodies. So there are some other special investigations when we want to see for any medullary carcinoma or any genetic carcinomas, then we have to order for thyroglobulin or calcitonin. They also act as a tumor markers also. And then we go for thyroid scan, that is the radioiodine scans. So what basically under the hypothyroidism, one of the commonest thing comes under is autoimmune thyroiditis. Okay. So Hashimoto's thyroiditis is one of the very common diagnosis. It accounts for 90% of the cases of hypothyroidism, except in areas where iodine deficiency is endemic. In those areas that there could be hypothyroidism because of that. So what we do, there could be even sometimes when we do the radioiodine therapies or like thyroidectomies, then there also hypothyroidism has been reported, and definitely female incidence is much more common than the male incidence in cases of hypothyroidism. That is 6:1 ratio is there. Then about the primary hypothyroidism, that is when we call it as primary hypothyroidism, we have read that TSH level has to be elevated in case of primary hypothyroidism. But how much it should be elevated? It should be around greater than 10 milli international unit per liter. Many times we are like in very dicey situation, or we are biased when we read the level 0.5 to 5.5, then we just keep on thinking how much high we should start the treatment and all. So if you want to label that the patient is having a primary hypothyroidism and not a subclinical hypothyroidism, then you have to see the TSH level. It should be more than 10 milliliter unit per liter. So there has to be, there are mostly thyroid peroxidase antibodies are positive. When it is subclinical, then it is the level is between the 5 to 10. So how we usually manage? We usually manage with oral levothyroxine. And here you have to take this important message is that we have to start the dose like 1.6 microgram per kg per day. How you will start the dose? 1.6 microgram per kg per day on an empty stomach. Dose has to be taken on an empty stomach. And in subclinical hypothyroidism, usually you directly start with the levothyroxine. That dose is 25 to 50 microgram per day. Okay? Any range depending on what is the level of the TSH. Between 5 to 10 it is the level, and between 25 to 50 you can keep the drug dose. So you have to repeat. This is also like many of the students used to have the questions when to repeat the TFT. When you are starting the hypothyroid management, you should get once you have started the treatment, at least after 6 weeks you have to repeat the test. So dose of the thyroxine is to be adjusted, and it has to be maintained as per the TSH level. So what is the reference range you want to attain? What is the TSH range you want to attain? You have to take that into account, and you have to readjust the dose as per the TSH level. So one thing you have to take into account here is T4 should be taken into upper part of reference range. So whenever you are seeing the TSH, you should see T4 also. And after the treatment, you should take a point in your mind that T4, I have to keep it in upper range. You should keep the T4 in upper range. Then levothyroxine therapy can even reduce your goiters and nodules in up to 50% of the cases. Nowadays, there is an imaging system, Thyroids. There is an FNAC grading system also, separate FNAC grading system also, that all says that you don't need to operate even the nodules are less than 4 centimeter. You should keep a wait and watch. And if they are not in euthyroid status, definitely you have to start the treatment and then think of the surgery. Don't directly go on to surgical management. So thyrotoxicosis, it is a very broad term actually. Okay. So it is basically, you can tell whatever the manifestations are going on in the body, in the system, systems like your cardiovascular system, your brain, or your peripheral system, whatever the manifestations are going on because of the high level of the thyroid hormone, it is called as thyrotoxicosis. Okay. It could be because of increased production. It could be because of any increased release, or it could be because of any exogenous supply we are giving. So hyperthyroidism is one of the entity inside the broad term thyrotoxicosis. That is the increased thyroid hormone due to increase in either synthesis or secretion. Two S are there, synthesis and secretion. So it could be in the Graves' disease. It could be in the MNG, that is multinodular goiter with toxicosis, or it can be in the factitious thyrotoxicosis. Okay. So what are the first line of investigations? Again, the same basic investigations, T3, T4, TSH. You should actually look on for the ratio of T4 and T3. So typically, there will be 30:1 ratio in cases of conventional thyrotoxicosis. Okay. So T4 will be 30 times higher than the T3 in cases of conventional thyrotoxicosis. While in cases of factitious, that is a very false rise. So in that case, T4 will be 70 times higher than the T3 in case of factitious. So when it is very high, बहुत ज़्यादा उसमें extra आपको लग रहा है gain हो रहा है, that means it is not a true report, it is a false report, or some false other things are going on rather than it is a conventional or primary thyrotoxicosis. TSH receptor antibodies we can advise. Then radioiodine uptake scan are very good to differentiate between hyperthyroidism and thyrotoxicosis. So with the technetium 99, we use this. Okay. So here are this basic imaging images. This is the right and left side, and it is the sternal notch. Here are this side will be your salivary glands, and this is your thyroid gland. Okay. This is the normal imaging. Okay. So these are the different pictures where you can see there is the decreased uptake or a silent nodule is there. It is the cold nodule. Okay. There it is the pyramidal lobe. It is the higher uptake in these two sides. You can see there is the higher uptake. It is the Graves' disease. Then toxic nodular goiter. All are like multiple hot and cold nodules are there. Here will be the cold nodules and here are the hot nodules. So it is the toxic nodular goiter. Here there is the extra uptake. It is the hot nodule. Other area is suppressed and this is another very prominent nodule, that is the hot nodule. Autonomous nodule is like one side of the gland will be very like very suppressed and another will be like very high uptake will be there. So complete suppression of the other gland and one gland is very prominent, that is like differentiates between the autonomous nodule and the toxic multinodular goiter. Okay. And in the this thyroiditis case, radioiodine uptake will be less than 5%. Very less uptake will be there. Uptake will be there, but very less. So here is the another picture of what we have seen in the previous picture. This is the cold nodule. These are the whole gland is enlarged. So looking same like a hyper uptaken. So it is like the warm nodule, and hot nodule is the like very prominent one nodule is there. So that will be the whole hot nodule. These are the equivalent depiction of the two pictures. This is the whole hot nodule. This is the warm nodule, and this is the cold nodule. Warm nodule, we can say it is a warm gland basically. So how to manage these thyroid toxicosis cases? Definitely anti-thyroid drugs. Commonly used anti-thyroid drugs are your propylthiouracil, your carbimazole, and propranolol also we used to give. Then radioactive iodine therapy is also given as a management part, and surgery. For Graves' disease, you are not able to control the hyperthyroid status and you have to do the Graves' disease because of the higher uptake of the nodules. So common medical managements you have to do because there is a risk of atrial fibrillation in 10% of the cases. So in that cases, we used to advise beta blockers. Basically, we use the non-selective beta blockers, and commonest one is your propranolol. What exactly the propranolol does, it basically blocks the conversion of T4 to T3. So non-selective blocker, one thing it has to be taken care, you have to ask the history of asthma. If in the asthmatic cases, you have to just think of giving the you should not think of giving the propranolol. Then in that cases you can give the selective blockers like verapamil and diltiazem. So let us have something about the Graves' disease, because many of the cases used to come of the Graves' disease, even they present with Graves' ophthalmopathy. So it is important in both ENT and in ophthalm cases also. So what is basically the pathophysiology? In short, behind the Graves' disease, it is like the production of the immunoglobulin antibodies directed against the TSH receptor on the thyroid follicular cells. जो TSH receptor है वो कहाँ present है? Where they are present? They are present on the thyroid follicular cells. So antibodies are present, produced in the body against the TSH receptors. So we advise in Graves' disease TRAB antibodies, that is TSH receptor antibodies are being advised. So what they do basically, these antibodies stimulate the thyroid hormone production and proliferation of the follicular cells, and that leads to the goiter. They are positive in 80 to 90% of the cases. So basically they could be either stimulating, they could be blocking type, or they could be neutral type. So there are various presentation in the Graves' disease also, depending on what these antibodies are doing. So what you will do, basically beta blockade, already told, anti-thyroid medications, already told, then iodine 131 surgery, or first you should try for radioiodine, and if it doesn't treat it, then you should go for surgery. So how to how to do the management of the things and how to use these drugs? Okay. So anti-thyroid drugs commonly used are carbimazole and propylthiouracil. So it should be mostly used in age less than 40 years, and contraindications are breastfeeding. In those cases, if you at all want to give, you don't give carbimazole. You should prefer propylthiouracil. Okay. And what are the disadvantages? There are not like very severe things are not there, but hepatotoxicity could be there with propylthiouracil. but it could be fatal also. Usually it doesn't like very less incidence is there, still it could be there. Okay. So in cases of subtotal thyroidectomy, when we do the subtotal thyroidectomies, in cases of large goiters, when there is poor drug adherence is there, when patients are not coming up in proper follow-up, recurrent thyrotoxicosis is there even after the antithyroid drugs, then you will have to go for surgical interventions. Okay. So contraindications are like already previous thyroid surgery has been done, or there is like whether the occupation in foreign countries, it is like too much of importance is given to the patient's profession and all, whether it will be disturbing cosmetics and all. So if a patient is like a lecturer or singer, so we will think on the surgery, we should not do actually. And what are the disadvantages or complications it may lead on to? You all know there could be hypocalcemia, hypoparathyroidism, recurrent laryngeal nerve injuries and all. So radioiodine therapy is usually less than 40, we were preferring antithyroid drugs. More than 40, we are preferring radioiodine. Or even in cases of recurrence after the surgery, we used to give radioiodine therapy. Contraindications are mostly pregnancy, or if patient is like in conception stage, that then also we are avoiding the radioiodine therapy. And also in cases where within there is a active graves ophthalmopathy, when there is a active graves ophthalmopathy, then also we have to contradict. So what is the starting dose of carbimazole? So mostly we used to give 5 milligram TDS. You would have heard about the treatment. So in subclinical hyperthyroidism, when it is in a subclinical state, we used to give between 5 to 10 milligram per day. Okay. Then overt hyperthyroidism is there. If it is overt, then you have to see if T4 level is less than 20, you will start 20 milligram per day. If it is more than T4 is more than 20, 20 is your baseline. So if it is less than 20, 20 milligram per day. If it is more than 20, then you will have to adjust the dose between 30 to 60 milligram per day. 10 milligram carbimazole is equivalent to 5. This equation also you have to like keep in mind. You have to learn this, that 10 milligram of carbimazole is equal to 5 milligram of methimazole. That means methimazole is doubly potent than your carbimazole. Then 10 milligram of carbimazole is 100 milligram of propyl thiouracil. Okay. So in that way you can adjust. If you are thinking ki propyl thiouracil I should give or carbimazole I should give, both you can give. And in the last slide I have already shown that in which cases you have to give propyl thiouracil, in which cases it would be contraindicated. The hepatotoxicity is there, then you have to think of giving the propyl thiouracil, you should not give. And if breastfeeding is there, then it is like if it is going for breastfeeding, then we should give like we can give propyl thiouracil. Then monitoring, somebody was asking me the previous slide, so I am again showing this slide. If at all you people want, I can share this lecture on, if any group is there, I will share this lecture on that group. So monitoring of TFT, I've already told, once you have started the treatment, then you should monitor the TFT at 6 to 8 weeks interval till you get your desired T4 level and TSH level within the reference range. Got it or not? You have to see for the T4 level. Okay. T4 level has to be kept on the upper range, and TSH level has to be kept within your range of the normal TSH level. Okay. Overt hypo and hyperthyroidism are at the level of 10 microgram. Okay. Treatment duration, you have to treatment duration means what you understand. Once you would have heard that once you are taking the drug for hypothyroidism, you have to take it for lifelong. Once it is hyperthyroidism, if we are achieving hypoeuthyroid status, then it is okay. But for hypothyroidism, it has to be taken for lifelong. But it is not like that. Definitely treatment will go on for 12 to 18 months at least. After that, if continuously you are getting your TSH level in the desired range and T4 level in your reference range, then you can think of stopping the medications after 12 to 18 months. So what are the adverse effects of these drugs? Most common is rash. So rash is not a big problem. Then agranulocytosis is a rare but a serious complication. Then propyl thiouracil is associated with definitive small risk of hepatotoxicity. Propyl thiouracil mostly is a reserved drug in cases of emergency and pregnancy in cases of first trimester. Then what about the radioiodine 131? There is a misprinting, 131 it is. It is given as a oral and it is given as a single dose and it is 10 to 15 microcl. Okay, so it is the single dose of radioactive iodine and it is given in cases of in the form of oral formulation. 131 emits what rays? Beta and gamma radiations. What rays it emits? It emits the beta and gamma radiations. And it has the inhibitory effect on survival and replication. Even it doesn't allow the survival and even also it protects the replication of the follicular cells. You should not give both the things together because carbimazole will reduce the efficacy of radioactive iodine 131. So you should not give both the things together. That carbimazole also you are giving and radioactive iodine therapy also you are giving. You are thinking that you will suppress the things very quickly. It is not like that. There will be opposite effect. That like we say na, when same poles repel each other. So they have got the opposite effects and should be avoided until 48 hours after radioiodine therapy. And there is a relapse after 6 months, then we can repeat the dose. Even though it is a single dose, if after 6 months there is a relapse, we have to repeat the dose. So what are the disadvantages? Eventually, it can lead on to hypothyroidism. And it has to be avoided in patients with Graves' ophthalmopathy because it will create more of orbital inflammation. Even though if it suppresses the immunoglobulins, other inflammatory mediators will increase. So we avoid radioiodine therapy in cases of Graves' ophthalmopathy. And then we have to give sometimes the steroid cover for a 6 week. And pregnancy has to be excluded. There is one this slide single slide I'm showing in relation to our imaging system. One thyroids has been given. Mostly it has been asked like in many of the quiz, many of the short questions. It is asked that what is the short form of full form of thyroids. Thyroids is a grading system, which is a radiological grading system depending on the findings in the sonography for the thyroid nodules. So that full form is your thyroid imaging reporting and data system. What is the full form? Thyroid imaging reporting and data system. So it has got 5 grades. So how it is correlated, how these grading systems have been formed. Like you have to, there are 5 grades. Like we will start from thyroids went down. It is the normal thyroid ultrasonography, the normal echogenicity, normal nodularity, normal surface. If everything is normal, then we call it as a normal thyroid ultrasonography, and that will correspond to thyroids 1. Then there is thyroids 2, and it is like benign aspects. What are all the benign aspects? When there is a simple cyst, when there is a spongiform nodule, when there is a white knight aspect, then there is isolated microcalcifications, then there is subacute thyroiditis. All these entities, whatever I am telling, are you can give the points. Like simple cyst is present, 1 point you can give. Single cyst is not there, you can give 0. Spongiform nodule is present, then you can give another 1 point. So in each of the grading, like under the thyroid ones, there is nothing. Under the thyroids 2 also, you can have a calculation like 1, 2, 3, 4, and overall calculation you do actually in these cases. So benign kab hoga? When it will be benign? When there is isolated macrocalcification, when there is presence of subacute thyroiditis, or when there is simple cyst is present. That shows it is thyroid 2 or it is like a benign. Then one thing is like probably benign. You are not very sure. Okay. So it is like a neutral state. That is thyroid 3. When the lesion is isoechogenic or hyperechogenic. In the both the cases, there are no different heterogeneity or something like that are there. No other macro micro calcifications are not there. And only thing is either the lesion is isoechogenic or hyperechogenic. Then you are not sure whether it has got some malignant component in it or not. Then comes your thyroids 4A. In this case, there are no very highly suspicious aspects are not there, but moderate hypoechogenicity is there. Whenever there is a hypoechogenic lesion, it goes more in favor of malignancy. So thyroids 4A is like low suspicious aspect of the any nodular lesion. Then when the gland is very highly suspicious for like malignant thing is when they are taller than wider, more tall rather than wide. Then there are irregular microlobulated margins. There are microcalcification. We have seen in thyroids too that macrocalcification is an indicator of benign aspect, while microcalcification is an indicator of your malignant aspects. Then marked hypogenicity, echogenicity is also an indicator. So if like more than 3 signs are there, then we call it as thyroids 5. And when 1 or 2 signs are there amongst this high suspicious aspects, then we call it as thyroids 4B. Thyroids 4 has been graded into 4A and 4B. So 4B is basically a part of 5 only, but when the signs are less than 3, then we call it as 4B, and when there are more than 3, then we call it as thyroids 5. Now come to the post-thyroidectomy management of the things. Any complications we have done, you have decided this patient is euthyroid or this patient needs surgery, you will definitely go for thyroidectomies. So once you have done that, then you know there are few complications which you can avoid, but if it happens, then what you will do. Okay. So total thyroidectomy, if you do, you are sure you will have to give thyroid hormone replacement. For sure, you will have to give thyroid hormone replacement. Once you have done the lobectomy, there could be associated incidence of biochemical hypothyroidism, and there could be overt hypothyroidism. So there are two types of hypothyroidism. That is, either there is a chemical hypothyroidism or there is an overt hypothyroidism. Okay. So there is an incidence quoted in the literature, 22% biochemical hypothyroidism and 4% hypothyroidism. So now you have to do the assessment for the hypoparathyroidism. If it is symptomatic, we have to do the further assessment, either clinical assessment or you have to do the hormonal assessment. Then you have to wait for the final histopathology report also before doing the complete final management or ordering some parathormone or other higher investigations. So whole body iodine scan once TSH is greater than 30. If TSH is more than 30, then you have to think of differentiated thyroid carcinoma or papillary thyroid carcinoma. Then what are the features of, parathyroids are adjacent to the thyroid. If you have not preserved the parathyroid supply, if you have not seen properly the parathyroids, you are definitely going to injure the parathyroids, and there will be definitely a overt clinical or subclinical hypoparathyroidism will be there, and that will manifest as hypocalcemia. So mild hypocalcemia is usually asymptomatic, When there is severe hypocalcemia is there, then there will be tetany. So what is tetany basically? It is the muscle spasm because of there is very increased excitability of the peripheral nerves. So what it basically comprises, mostly there will be carpopedal spasm, stridor and convulsions. If you say proper tetany, if it is there will be three things: carpopedal spasm, stridor and convulsions. So if those who are doing the residency, they would have seen in cases of tetanus, usually there used to be have stridor, and we have done tracheostomies in cases of tetany. In diphtheria and tetany, these were the two cases which used to be kept in isolations, and many a times tracheostomy need to be done because of this presence of this triad sometimes. Latent tetany is because like mild hypocalcemia, but it may get precipitated sometimes. So sometimes how you come to know, when you are taking the blood pressure in the evening, you are taking the rounds and you are taking the blood pressure, and you insufflate or inflate your sphygmomanometer, and there is suddenly the carpopedal spasm, and it usually takes 3 minutes to manifest this Trojer's sign. That is the carpopedal spasm. I will tell you in the next slide, show you the diagram how the hand looks like when you do the Trojer's sign. Chostak's sign also, when you tap over the branches of the facial nerve as they arises from the parotid gland, it causes the twitching of the facial muscles. Okay, this is the method of eliciting the. You just tap on the branches of the facial nerves. You have to know the surface marking of the all the peripheral branches of the nerves, and just as the like the exiting point from the parotid, you have to tap the nerve, and there will be constant twitching. That is called as Chostak's sign, and that will be positive in cases of overt hypocalcemia. This is the Trojer sign. That is the typical like hand position. What it will be, basically, there will be flexion at the wrist, and there will be also flexion at the metacarpophalangeal joints. There are two flexions, one at the wrist and one at the metacarpophalangeal joints. So when you raise the cuff about 20 mmHg above the systolic blood pressure and you wait for 3 minutes, that will precipitate this sign. So how to manage? Like there could be many symptoms like tetany, seizures. So what you have to do, there is a one rule of 10 that give 10 ml of 10% calcium gluconate intravenously over 10 minutes. What is rule of 10 for the management of hypocalcemia? That is 10 ml of 10% calcium gluconate intravenously over 10 minutes. So this you have to keep in mind. Okay. So then we have to proceed into step number 2. What is the step number 2? Mix 5 ampoules of calcium gluconate to make it around 500 milligram, and that you dissolve in 500 ml of 5% dextrose. So second step क्या हो गया? 5 ampoules of calcium gluconate in 500 ml of 5% dextrose. So 1 ml equal to 1 milligram of calcium gluconate. 1 ml of calcium gluconate, if you take, then it will be equivalent to 1 milligram of calcium gluconate. So initial infusion rate you should keep on. How much it should be given? 0.5 to 1 ml per kg per hour. What is the initial infusion rate? 0.5 to 1 ml per kg per hour. So maximum infusion rate you can keep 2 ml per kg per hour. Okay. Step 3 is for in which cases? It should be in chronic or minor hypocalcemic cases. What do? You just give टैबलेट कैल्शियम कार्बोनेट 2.5 to 5 ग्राम पर डे. एक कैल्शियम कार्बोनेट की टैबलेट is around 500 milligrams. So you have to give 4 to 5 times per day. So tablet calcium carbonate 2.5 to 5 gram per day. And along with that, you should give capsule calcitriol 0.25 to 1 microgram per day. So this is for the chronic or minor hypocalcemic cases. When there is like persistent hypocalcemia, you are like giving all the things and still hypocalcemia is not coming under the control, then you have to think of, because calcium and magnesium metabolism and all these things go together. For the TSH activation and thyroid hormone secretions, magnesium is also important. So you have to start the magnesium replacement also. So like I'm done with the most of the part, like relevant things I've taken. It is a long topic to cover whole of the thyroid in a single sitting. So I have taken all the salient points which are like mostly confusing and we frequently come under the clinical scenarios that I have kept. And these are the things which I have want you to read. Even though they are not in the lecture, you have to read before going to the bed. And I think I'm done with the lecture. Thank you so much. And now we will go for the queries. We can have an interactive session now, because in between I have not taken any questions. Thank you so much.
Ma'am, you may stop sharing the screen, ma'am, and there are please query in the chat box.
1 second. Yeah. Somebody was asking, those who want to ask the question, can they themselves unmute and they can ask the question? Host, can you do that for me?
Whoever want to ask any question, just raise the hand.
Hello, ma'am. Thanks a lot for the class. It was really informative. Thank you.
Thank you.
Ma'am, kindly repeat the surgical anatomy of thyroid regarding the tracing of the recurrent laryngeal nerve and the vascular anatomy.
Okay. Do
Kindly.
you want me to show the slides again?
Yeah, slides and a bit of
Bit is like, देखो, first and foremost things, I might have forgotten to show you the triangles, important triangles.
yeah,
Basically, two important nerves are there, superior laryngeal nerve and the recurrent laryngeal nerve.
recurrent
So
laryngeal
for
nerve.
superior laryngeal nerve, you have got one important triangle, that is your Jones triangle. All of you know?
Yes, right. Yes, ma'am.
You can just type yes, why, just why, if you all know. Okay, there is one triangle, that is Jones triangle, where I was saying this Serenia classification, that is the same space. There you have to trace your superior laryngeal nerve. Okay, then comes your most important is your with the superior laryngeal nerve, what will happen if you like damage the external branch that is supplying your cricothyroid muscle? So motor function will go for one side if you are doing the hemithyroidectomies. Okay, and if you are doing the total, both sides, there is the chance you can damage once it is in the Sarnia type 2b, that is for the superior laryngeal nerve. And internal branch, it supplies the sensations above the level of the true vocal cord. So
Vocal cord.
above the level of the true vocal cord, if sensations go on one side, then it is usually compensated by the other side, and there won't be much of the aspiration problem. Some husky voice, or whenever somebody will drink, there will be sudden coughing off, like this will be there, but it won't cause very major problems to the patient. So we are worried, like voice is your like symbolic of your, जैसे आवाज ही पहचान होती है ना सबकी, तो वो वाली चीज है, तो people are more worried of the recurrent laryngeal nerve. Bilateral recurrent laryngeal nerve palsy is definitely a very problematic, because patient will go into the stridor. Okay,
Right.
so
Yes, ma'am.
you have to trace the recurrent laryngeal nerve, and there are the triangles. Like various triangles have been depicted. One most important triangle is like Bear's triangle. Okay, so in Bear's triangle, there are three boundaries: common carotid artery, inferior
Mm.
thyroid artery, and one of the branches, one of the side is your recurrent laryngeal nerve itself. Okay,
Yes,
so common carotid space कहाँ है आपकी? Thyrocarotid space. So this is the carotid, this is your thyroid. Okay, and inferior thyroid artery is coming from here. So this common carotid, this is inferior thyroid, and the third branch is recurrent laryngeal nerve itself. Okay, so if you are if you even don't say ki I am don't know the Bear's triangle, then don't worry. If you are seeing the inferior thyroid artery, mostly it will pass beneath the inferior thyroid artery. Okay, recurrent laryngeal nerve will be beneath the inferior thyroid artery mostly. It can be above also, or it can be just going little bit lateral to it. So whenever you see the inferior thyroid artery, you should be careful. You have to search the recurrent laryngeal nerve around it. And if you are doing the capsular dissection of the thyroid, you are always finding the superior parathyroids, because superior parathyroids are the most consistent parathyroids. Inferior parathyroid may vary in their position, or even they may be present or absent. Okay, so superior parathyroids, if you see, they will just point down to the recurrent laryngeal nerve. So once you have seen the superior parathyroid, just as your eyes see the superior parathyroid, the eyes of the superior parathyroid will see your recurrent laryngeal nerve. Okay, then there were two other things I said to you people, that is tubercle or Zuckerkandl and Berry's ligament. They are also the they also point to the recurrent laryngeal nerve. That means recurrent laryngeal nerve will pass beneath the tubercle of Zuckerkandl. Okay, So these are the few important things which we can help you to trace. And definitely tracheoesophageal groove itself is one of the landmark. In the like right side, you have to be, this is your trachea, medial to the trachea will be esophagus. Okay. So in the right side, the recurrent laryngeal nerve will be just seen. Once you medialize your right side of the gland, you will see the recurrent laryngeal nerve. While in left side, it will be little deeper. Between the trachea and esophagus will be your recurrent laryngeal nerve. And one another thing is we have learned by our surgical experience that where at the cricothyroid joint, this your recurrent laryngeal nerve enters the larynx. So if you can identify the joint, you can trace the retrograde also. Yeah. So both ways you can trace the recurrent laryngeal nerve. Anything else?
Ma'am, can you please show the jaws triangle? The bears I could understand.
Shall I show you the slide?
Yes, ma'am.
Yeah, I will show you the slide if that makes you better understanding.
And there was one avascular plane where the inferior thyroid artery was going.
Okay, okay. I will show all this. Host, could you please allow me to share the screen once? This was the space you were talking about. This is the thyrocarotid space. This is the thyroid gland. Okay. Here is the carotid, and this is the inferior thyroid artery.
Yes.
Is it clear?
Yes, ma'am.
In this also, you are retracting the strap muscles. Here is your internal jugular vein. Here is your external carotid artery, and here is your inferior thyroid artery. Got it?
Yes. Thank you, ma'am.
Is it clear or is it not visible? Shall I?
No, ma'am, it's visible. Thank you.
Okay.
Thank you, ma'am.
Any other questions?
Ma'am, in
Yes.
hyperthyroidism, if there is multinodular
Hyper
goiter,
or hypo?
hyper increase.
Okay, okay.
If there is multinodular goiter, single solitary thyroid nodule, or there is Graves' disease. So in all three, we will give same drug carbimazole, or we can try something else also.
No, no, we will give that. And but in case of if it is solitary thyroid nodule, we have to be very, you all know, if there is a single full nodule is there. If uptake you are going for, then it is okay. You will be able to know whether it is a hyper toxic nodule or a simple nodule. But if you are not doing the radioiodine uptake scan, then you will not know whether it is a cold nodule or it is a warm nodule or a hot nodule. So in those cases, if hyperthyroidism symptoms are there, you can go for any of the drug, either carbimazole or propyl thiouracil. But the additional drug that is propranolol, it is given when patient is frequently landing into irregular like pulse. You have to, one thing you have to consider in the thing is cardiovascular system.
Ma'am, in Graves' disease, can we try some immunosuppressive treatment and in Hashimoto's also?
In Hashimoto's, as such immunosuppressants we are not giving except for your prednisolone. You are giving steroids in cases of Hashimoto's.
Ma'am, if the patient gets hyperthyroidism during treatment, if we are giving levothyroxine
Huh.
and patient has become hyperthyroid, now we need to stop the drug. So we abruptly stop it or we taper
No,
it.
we should gradually stop. We should not abruptly stop, as we have adjusted the dose for TSH reference level when starting the treatment. Same is done to taper also.
By how much dose we will taper if like TSH level has gone to about 1 or 2 and T3 T4 has raised about 7 or 8.
So what we want to aim is, first we
How-
will take them to the subclinical level, and then we will take them to the lower level. Okay. So in cases of our levothyroxine, it was 1.6 microgram per kg body weight. Okay. You are asking for hyper or hypo? Hypo, na?
hypothyroidism we were treating, we were giving levothyroxine
Yeah,
and
yeah.
it gets overdose. So
You initially whatever dose you are giving, then you have to reduce it in the same way, 1.6 microgram per kg per day.
okay, ma'am. Thank you, ma'am.
Any other? Anyone else, or we should like, shall we wait host, or we shall call it a day off?
There is no more guidelines.
Ma'am, what's the warm? What's the difference between warm and hot nodule?
Warm is like
Hot
there
means
is a similar uptake in whole of the gland. Whole of the gland is like hyperactive.
normal. There is something hot and one thing is warm.
Yeah, hot is like it will be a toxic nodule. It will be like at one place there will be a hyper uptake, and rest of the places there will be a normal uptake. While in cases of warm, even there is a hyperactivity, but it will be similar in all the areas. Is it clear to the student who was asking about like hot, warm, or is there still any confusion?
No, ma'am. Thank you. Thank you. Thanks a lot, ma'am. Ma'am, can we get this PowerPoint presentation?
You can just send me, like I will send this on mail. You those who want, they can just ask me or they just WhatsApp me their mail IDs. I will send them.
Ma'am, where to WhatsApp? We don't. Okay. Have you shared your email ID?
You people have some group? I don't know really. If you people have some group, even I can share on that.
No, ma'am, we don't have a group.
Is there any common NBE group?
No, ma'am, there is no group.
Okay, then I will just message you in my chat box. I will message you people.
Okay, ma'am. Thank you. Thank you.
Any other question? Before leaving, I would like to have a brief feedback from you people so that we can improvise it on later. Any one or two students, could you please let me know if any like any issues you faced in between the lecture, because I don't know, I was constantly speaking and there was no interaction in between.
No, ma'am, there were not any interruptions between the classes. So thank you, ma'am. Thank you for
Thank you so much.
thank you all attendees for joining this session.